A very good afternoon to all viewers. Today, with the help of Subanjaya Medical Center, we'll be conducting a GP dialogue. The GP's role in brain injury among the elderly due to fall by our very own resident consultant neurosurgeon, Dr. Gurmit. I would like uh, to start with a short intro about our speaker today. Dr. Gurmit started his specialized career as a general surgeon in Alusta, that is in 2000 and 2001. He was selected to be the trained as a neurosurgeon in GHKL. He had a stint in National Neuroscience Institute, Singapore, before joining the fellowship program in Australia. On his return in 2006, he was posted in Penang GH as a head of department, covering the northern region. During his 6 years there, he developed his interest in tumor surgery, pituitary surgery, and pediatric surgery, for which he went to Paris and Istanbul to learn from the renowned pediatric surgeons. He returned in HKL in 2014 as a senior consultant and has joined SJMC as a resident neurosurgeon since then. His current passion is brain injury caused by accident, stroke, and infection. And Dr. Gurmit, the floor is yours.
Hi. Sorry, Dr. Vara.
Yeah, no worries. I have already made the introduction. Is the floor is yours, doctor.
Right. Yeah.
You can start this slide show.
Yeah. Thank you. Thank you, Dr. Vara. I chose this topic because commonly when we treat patients and you send patients back, you wish that some of the message that you want to give to the patient, you also can share with the primary care physician, the general physician, the GP who will continue their care at home. Many a times the advice message you give to the family in their anxiety, in their haste, they might not be able to comprehend. So much information is thrown at them that they are not able to digest the information. Hence, I take this opportunity to share this information, this knowledge with my GP colleagues who will continue the care of this type of patients in their locality, in their suburbs. Now, quickly, let me run through a couple of things that an elderly patient can sustain. What type of head injury they can sustain. An extradural, meaning, if you recall, let me quickly run through. If this is the head, I remove the skull, and this is the dura. Quickly, this is the dura. Anything above that is known as extradural. Anything below the dura is known as subdural. And then there is a contusion that is when the brain is lacerated, then intracerebral, what happens within the brain, then traumatic subarachnoid hemorrhage and intraventricular hemorrhage. I'll run through each of these in detail shortly, but the primary cause, especially in today's discussion, we are talking about low impact floor level falls or low height falls less than 3 meters, commonly seen in elderly. You're not going to see the typical falls that we see, the typical injuries that we see in the younger population who have high impact injury, acceleration, deceleration, motorbike, motor vehicle accidents. Now, quickly, let me run through here. Extradural, commonly associated with the fall. If you look at the extreme left, you can see the extradural in relation to a fracture. If you see where I put my cursor on, where the red arrow is, that's where a fracture occurred. And subsequent to that, you have an extradural, commonly described as lenticular biconvex shape. So, and watch very carefully what happens. It compresses the brain. This is what happens. The patient will start to deteriorate. Another example here. This is another one, another extradural. Subsequently, below, I've shown you a couple. It can happen anywhere around the skull, commonly associated with fractures, medial meningeal artery rupture, sinus injury. And if you operate, it appears rubbery, firm. So you can't make a small hole and suck it. You have to cut a flap around it, around the flap, and then remove the clot. Not very common in elderly. Why? Because the extradural is the dural layer is densely adhered, hard, very firmly adhered to the bone. Therefore, there's not much space for the blood to seep through. Commonly, not very common, unless it's a very bad type of fall where you have injury to the bad injury to the skull. Now, the next one is where we're going to focus some amount of time, which is commonly seen in the elderly. It can be acute, subacute, or chronic subdural. All are related to each other. And it happens below the dural layer. The diagram on the left demonstrates what I'm trying to say here, under the dura and above the brain. And this is where it compresses onto the brain and affects the brain function. Now, if you look in the center part of the presentation, anything less than 3 days is known as acute clot. Between 3 to 14 days is known as subacute clot, and the chronic one is 14 days. I like the significance is, if you're looking on a CT scan, looking at the color, we already can say what was the duration, when did this injury happen, when did the patient sustain the injury. And then you look at the bottom part, there are complicated varieties of chronic subdurals, the septated or the loculated. These are the tricky ones that the surgeon can operate, send the patient back home, it reaccumulates again. So the surgeons especially, we need to be very, very vigilant about this type of chronic subdural. The following one is the acute on chronic. You already have a chronic subdural, therefore the color, you look at the cursor that I'm showing to you now, this is the chronic subdural, but suddenly there was another injury, you hit your head somewhere, even a trivial injury. You woke up, you hit your head on the bedpost, you removing your clothes, you hit the cupboard, and you can sustain an injury. So that is known as the acute on chronic. Acute because it's hyperdense, and chronic because the hypodense earlier. And because blood is more dense, it falls down, it gravitates downward. Therefore, you see the layering effect. The hypodense layer on top and the hyperdense containing the fresh blood below. Now, to the right is the consequence or the effect of having such large amounts of blood within the cranial cavity. What it does is it pushes, although this is a diagram of an acute subdural, but I want to highlight to you what happens when blood accumulates within. So what happens is it pushes the brain, and there is tentorial herniation. It herniates to the tentorial notch, compresses the brainstem. There is also subfalcine herniation. This part where my cursor is, it pushes the brain to the opposite side below the forks. All this affects the function of the brain, and GCS will start to drop. Now, again, I want to highlight to you, in an acute situation, the blood is firm, rubbery, will not flow. Therefore, my incision has to be large enough to encompass the whole amount, all the blood that I can see on the CT scan. Therefore, the craniotomy is commonly in a question mark shape. So question mark runs through this. Here we are. Do keep in mind, I will discuss this further down the line. Look at where the incision, the posterior part or the back part of the incision, where it comes. And sometimes we even pull this even further behind if there's a larger amount of clot. This will come to haunt us later. If we do not take care, if we do not inform the family that please be careful how you position the patient at home, there can be compression onto this area. It can cause this area to be necrotic. So this is one thing I want to highlight at this stage. Now, you must also ask me, oh, how come elderly patient, I'm doing such a large surgery? There is no option, because the blood clot is quite rubbery, quite firm. It will not flow. You cannot suck it out. You have to cut the flap open to allow to allow us to view the clot and then only suck the clot away. Subacute, it's already become liquidy, it's become soft already. Hence, if you notice that the incision has changed in size, it's become much smaller. So you make a small incision and then open the skin, you see the bone, cut the bone. Now, I want to draw your attention to the capsule of the subacute subdural. It's this color, and commonly in surgery, our aspiration is our ambition is to remove as much of this capsule as possible. This capsule is formed because once we have a bleeding in there is release of mediators. You have fibrinogen, and then there are other kallikrein, other mediators that pull in a lot of new vessels. So you have capsule formation. You have on the capsule, you have new vessel formation. These new vessels, unfortunately, are very, very fragile, very, very small. So the slightest movement again causes them to rupture and bleed. Do note these are very small vessels, so you won't have torrential bleed. What happens is small amounts of blood are released, and when they release, they again produce chemical mediators that attract new vessels to form. So it's new vessels again are fragile, they bleed again and again. So this cycle repeats again and again. It's a vicious cycle. So it keeps larger and larger. So we try to remove as much as possible of this capsule. And once you remove the capsule, and this is the content, compare this with the earlier clot. This one is more shiny, more soft, but still not flowy, not liquid enough. I also want to draw your attention to the amount of space between the cranial wall. Here it's covered by the dura, and this is the brain. There is significant amount of space on removing this clot. Now, what is the problem with this space? It's a dead space. So that is, if you are lucky, the brain expands quickly, occupies the space, preventing any more accumulation of fluid within this space. But if you're elderly, 70, 80, 90, you have got atrophy of the brain, there's a lot of space between the bone and the brain. So it takes a bit of time, or it might not rise enough to come back to its original portion. So therefore, it leaves a lot of room for maybe the surgeon, as he's closing, some amount of blood seeps in. Maybe as the surgeon is closing, if you look very carefully, I'm pointing out to small septies, and these have blood vessels within them. They rupture and they will start the cycle all over again. So you will be quite surprised. Oh, just did the surgery a couple of weeks ago, how come it has reaccumulated again? So there is a possibility of the blood reaccumulating for the reasons I mentioned just now. And this is the chronic blood. Now the earlier acute, very large flap, the subacute, smaller flap, the chronic flap. The chronic one is the easiest one to address. Why? Because it's already flowing, and the appearance is of motor oil appearance. The color is in the capsule, in the container to your left. Now, what the surgeon does is make two small incisions, two burr holes, and then open the dura. By now you will realize that it's become chronic, it's become liquid, it's able to flow out of the holes that we made. And then with that, the structure, the thing that the surgeon is holding is known as the aseptor. Within that, it's a syringe actually. So it'll flush all the fluid within the cavity and clean off any residual amount of blood. I'm going on to the next type of bleed, subarachnoid hemorrhage. This bleed earlier was extradural, subdural, now subarachnoid. We know that the layers are dura, arachnoid, pia. So blood vessels sit between the arachnoid and the pia. So it's subarachnoid. All the blood vessels in the brain sit in this layer. Any type of injury can result in rupture of blood vessels within this and release blood to go within the subarachnoid space. The CT scan on the left shows you this. This is subarachnoid hemorrhage. I also, at this juncture, I want to let you know that many of these bleeding can happen at the same time. Extradural can happen with the subdural. Subdural can happen with the traumatic subarachnoid. Traumatic subarachnoid can coexist with the intracerebral. So they are not mutually exclusive. If the degree of the injury is bad, then you can have all in one. That is the prognosis becomes more grim. This is contusion. Now, the reason you get contusion is because the brain in an elderly person is already atrophied. So there's more room between the brain and the skull. So there's more room for it to move anterior, posterior, sideways, and all that. So therefore, slightest, even the trivial most injury will result in this the brain moving significantly. Now, I also want to highlight to you, looking at the skull, you will notice that the anterior cranial fossa is very rough. There are ridges here, number one. Number two, the sphenoid bone itself is very, very sharp. It's sharp. Same thing with the petrous bone behind here. So within the skull itself, there are many sharp and rough areas. So when the brain comes in contact with it, this is what happens. All this area, this is the frontal part of the brain, it gets contused. And this is the temporal part. This is the part that hits the sphenoid ridge and starts bleeding from here. This is the part that's resting on the anterior cranial fossa. Because the anterior cranial fossa has got a lot of ridges, they brush against this surface and cause contusions. Next, we go to intracerebral hemorrhage. Intracerebral hemorrhage, as this postmortem sample shows on the left, you due to the fragility or friability of the intracerebral vessels in an elderly person, even the smallest injury, the fall, can cause these blood vessels to rupture and they will bleed within the brain. So therefore, giving this appearance of CT scan on the right. You will see that this is the intracerebral hemorrhage. Again, a slight a note to all my fellow general practitioners. You will notice that I borrowed the same slide from earlier. There is an existence of traumatic subarachnoid hemorrhage here and the intracerebral. So both can coexist. And this is an appearance in postmortem. If the injury is very bad, then you can have intraventricular hemorrhage. So this just indicates to me the extent of or the impact that you had, the degree of impact, the degree of severity when I see intraventricular hemorrhages. My concern is heightened, and I'm very, very vigilant with this kind of patients. Now, I will stop here and highlight something is very, 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 very important. I must highlight this. A couple of weeks ago, I gave a talk on falls in the elderly. So, and I related these incidents that happened. It's a 60-plus-year-old retired school principal who was sitting in his hall, had a fall in his hall. Because of the commotion, the family came, picked him up, put him up on the sofa. He's saying, "I'm okay, no problem, don't worry." Had his lunch, able to talk to his family. There was just a small bruise on the temporal part. At post lunch, he retired to his room as usual to have his afternoon nap. At 3 o'clock, the daughter opens the door and sees him sleep. So she's comforted by that. She starts cooking dinner, and by about 5, 6 o'clock, she's wondering, how come my father's not awake? She goes into the room and then notices that he's not responsive. They rush him to the hospital, and in that, on arrival in ED, I was there. We did a CT scan, and this is around 6 to 7 hours post-fall, and there's a huge clot, intracerebral, subdural, within the brain. And I want to highlight to you, despite this gentleman waking up from the fall, from the chair, the family, talking to the family, having his lunch and all that, please do not disregard any head injury in a patient on anticoagulants, antiplatelets. In other words, anybody above 60, 65 who comes to you in your clinic, who's on anticoagulants, antiplatelets, had a fall, had an abrasion, you're suturing it off, or you're putting some dressing on it, please be mindful that I would suggest for them to at least make a trip to hospital, because aspirin and anticoagulants do increase the rate of your brain to sustain injury and have a bleed. And this further because there's so much of room between the brain, the atrophied brain, and the skull, that the blood has got time for it to accumulate within and slowly cause deterioration. In a younger person, where there's not much room because the brain and the skull, there's not much space, it quickly accumulates and causes pressure on the brain, and quickly symptoms will manifest. Here, because the space is so much, it can accommodate much more blood. So therefore, it bleeds over time. Patient is deteriorating slowly. So and like this in my patient just now, he went to bed and he never woke up again. So many of us also have reason. Oh, my father is tired, he's sleeping. Oh, he had a walk around the garden, he's tired, that's why he's sleeping. So please be mindful. Anybody above 60, 65, anticoagulants with a fall that you are suturing or some laceration that you are suturing, please advise them to come to hospital at least to get a CT scan. I agree the GCS might be full, but I think we must be very, very mindful of this. Now, how I divided today's talk is how the care after surgery now. After coming to hospital, how I want to, can work together with my GP colleagues will be, I've divided it into three parts. The first part is once he returns home, he continues his medical management of the existing medical condition, diabetes, hypertension, hypercholesterolemia, gout, whatever it is. So this must continue with the GP, the local GP or whoever he goes to. Now, the next thing is there's management of the non-operated conservative neurosurgical patient. For this, I will touch on subdurals. Sometimes the clots are small size. We don't do anything. We observe them 4 or 5 days in the hospital. Everything's okay. We'll send them back. With the advice is known as a head injury advice, but sometimes the family forgets or did not grasp the discussion, or even worse, did not grasp the gravity of the situation. Oh, it's okay, my father is not talking, he's well, he's eating, not an issue. But there are a lot of issues with that. The bottom one is the management of post-surgery patients. These are the separate group of issues that I want to highlight, I want to share with my GP colleagues. Now, what is the problem with a small subdural? When a patient comes to me, I see a small subdural, I observe him over a couple of days and I say, okay, not an issue. For 5 days, the clot does not increase in size. Your GCS is full. I want to send you back. But be mindful that the clot can increase and you can deteriorate. This is what I want to share with you. On top of that, if it's worse, if he has got aspirin and anticoagulants on board, what happens is the similar process like I mentioned earlier when I showed the earlier slides with the subacute and the chronic guys where you saw the capsule. The blood undergoes degeneration, it breaks down, it releases chemicals, it attracts fibrinogen, they form a capsule, new blood vessels are formed, again there's more bleeding, the volume increases, it increases the size, it compresses the brain, and it raises the intracranial pressure. So what happens is over the days, you see the patient starting to deteriorate. First day coming back from hospital, talking to the family, joking, watching TV. Third day, fourth day, now it's already 7 days post-trauma already. You start to see become a bit more drowsy, easily knocks off to sleep. Oh, the sad thing here is many family members have got a ready explanation. Oh, my father is old, just came back from hospital, very tired. Nowadays, his appetite is not that good. So there's always some ready excuse. So he starts to deteriorate over days, 7 days, 8 days, 9 days. You only realize when he does not wake up from bed, or he starts talking, or stops talking, or he slurred speech, or weakness in one side of the upper limb or lower limb because of the compression by the chronic subdural. So this, if you ask the history, did you have a fall? Yes. What did the doctor say? There was some subdural, and he observed him for 5 days. Now I noticed my father to be very slow, very difficult to wake him up. He doesn't want to talk. If he talks, it's very garbled, like he's drunk. So that is an alarm bell for you. Kindly refer him to the nearest hospital for a CT scan. The second thing here is there was a traumatic subarachnoid, or there was some injury to the brain. We observed him. everything is well, 5-6 days, and then you send him back. But because of the blood, you know that the blood flows within the CSF, and CSF is absorbed within the superior sagittal sinus, goes back into the superior sagittal sinus through the arachnoid granulation, which is on the walls of the superior sagittal sinus. Now, what happens is these blood cells, they block the arachnoid granulation. CSF cannot flow through, so it accumulates, it gets dammed up within the ventricular system. Ventricles dilate slowly, mind you, because the elderly folks have atrophied brain. They dilate. There's more room to expand, so they dilate. So, but at the meantime, the clinical features are already there already. Drowsy, starting to have headaches, nausea, vomiting, speech not very clear, difficult to wake up. You wake him up, short while later, he knocks off again. Then you come and tap, uncle, how are you? Open your eyes. He opens, he tries to engage you in a conversation, but then shortly, in front of you, he'll knock off to sleep again. Then you start waking up again. Wake up, uncle. He wakes up again. And then knocks off again. So that's very, very dangerous. At that stage, I think we don't want to reach that stage. That's why I'm sharing all this with you. That when you see these kind of features, I strongly suggest he needs to rush off to a hospital so that we can at least get a CT scan and see has the clot increased or is it just pure hydrocephalus. Third thing is, because of the injury, you can also get fits. They could be focal or generalized. I think here, this one I don't have to explain too much. You all are very, very experienced. A lot of senior GPs around who have seen this and you know what to do. Most likely you will likely refer to the hospital so that we can do a CT scan and find out what is causing these seizures. Now, these are the operative patients. These are separate ball game altogether, and we have seen so many problems with them that I'm drawn to bring this up with my GP colleagues, at least so that I can share this what we see in our hospitals very, very frequently. Commonly, what we do is we operate. Kindly bring your attention to this to your bottom right part of the screen. This is a craniotomy scar, similar like what I explained just now. The part marked in red is the one that frequently gets compressed onto the mattress, onto the pillow. And this is where the wound breaks down. Why? Because it's pressure. So the pressure sore happens onto the wound and the wound starts to gape, starts to break down. Now, once it breaks down, it starts to open up. Once you open up, the bacteria has already gained access already. Now, what will happen is there will be pus from the wound. The area is inflamed. You starting antibiotics at this stage is a bit dangerous because it requires much more. We need to establish, when it comes to hospital, we need to do a CT contrasted and see if there's any other pus beneath the skin flap further up, or if it has gone below the dura. So it become an empyema. So for this, if you see this wound breakdown, wound starting to become red, is inflamed, please refer to the hospital as soon as possible. The even more worse situation will be a surgical wound leaking clear fluid from there. That's a CSF leak. That's a near disaster already. Why? Because if the CSF can come out, bacteria can go in. So we are looking at meningitis, empyema, basically much more work. So if the GP thinks like, oh, I probably can treat with antibiotic, I think there's a bit dangerous solution to that. So I repeat again, if the wound is about to break, about to gape, the patient has got high fever and the area looks inflamed, there is some pressure sore there, please refer them. CSF leak, again, refer stat. If there's pus discharge, again, we need to see them as soon as possible. Now, the other thing that I want to highlight here is not in very old people, 50s, 60s. After we operate, what happens is, I draw your attention to this, where my cursor is. The skin gets stretched over the craniotomy wound. And this is where it becomes the thinness. It can necrose, it will tear. I use the word tear. and the bone will jut out like this. So that again is a very dangerous situation. Please send the patient back immediately to a hospital. Why? Because this bone which is exposed will become osteomyelitic, number one. Number two, once the skin, the incision has gaped, has torn open, the bacteria will gain access and you'll get a subdural empyema. The osteomyelitis itself is a headache to treat because you need to cut a very wide area, almost like orthopedics. So please, if you see any of these conditions, send back to the hospital. If the wound is not broken, please, and you see these kind of things, be it this one on the right or this, please advise, especially the GP is still has not deteriorated. The GP can still say, please be careful at home. Do not apply compression onto this your mattress. Please be careful. Your pillow. Please be careful of this. What I employ sometimes is I'll make a bridge. I'll roll up a cotton or a towel and put one under the neck and one more above the upper part of the head, trying to avoid compression onto this. So I make two bridges. So the head, one under the neck. If this is the head, one under the neck here, one under the neck. So you lift the head up and one this part here. So there's no contact with the bed, this side or this side, bed or the mattress. Basically, you are elevating the head up so that these pressure points are not touching either the pillow or the mattress. Again, I'll repeat, if you put a roll towel here, this will lift it up, and if you put one more towel here and turn the head slightly so that this does not come into contact with the mattress or the pillow that is resting on, we can avoid this problem. Or if the family is very diligent, they can come regularly, check and see the head is always turned to the left until the wound heals. The wound heals within 7 to 10 days, the wound would have healed already. Then should not be any problem. Now, after that surgery is done, the surgeon decides, hey, I want to do a cranioplasty so that the deformity is corrected. You either can use the patient's own bone, titanium, whatever. There's so many materials in the market. The issue here is we'll do the surgery, we'll send the patient back. Some surgeons like to do CT scans post-surgery, some do not like to do. If patient is well, GCS is full, I'll send him back. Some are like that. Some would like to do a CT scan and pick up if there's any extradural. That means between the artificial bone or the titanium and the dura, there's something accumulating there. The problem with that is it acts like an extradural. It will compress onto the brain. So over the time, when the patient is going back home, you can see the patient starting to deteriorate. Normally, extradural we can pick up quite fast. We pick it up in the ward itself. But it's the subdural. What you're seeing on the screen now is the subdural that's a tricky one. It can turn into a chronic subdural, like how I explained earlier, and compress onto the brain. Or over the next couple of days, it can bleed, and accumulate within the subdural layer and cause problem. And why does this happen? Because you saw the earlier part, how the skin is so sunken. I'll show it to you here. If you bring your attention to this, this is so sunken. As you separate the skin from the dura, you can do a lot of damage. You're using instruments to separate. As you're doing this, you can injure the brain underneath. You can cause contusions. You can cause bleeding. As you separate, a wider area or more depressed one is more challenging. Why? Because the skin is very tightly, densely adhered to the dura, and as you're separating, you are liable to cause an injury. Commonly, it manifests quite fast. You can have a seizure post-operatively. If it's an extradural, it deteriorates immediately. Then we rush to the CT scan room to get a CT scan. But the insidious one, the slow ones, are the subdurals, which can turn into chronic subdural, which is bigger problem. And the manifestation, the symptoms will be same like I mentioned earlier. Chronic subdural slowly start to deteriorate. Doesn't want to eat. Saliva is starting to drool, cannot swallow, become drowsy. Speech is starting to become garbled, almost stroke-like. Sometimes we insert shunts for the earlier problem, like I mentioned, hydrocephalus. Now, what can happen to the shunt? If you in your clinic come into contact with this, I would suggest the history of headache, vomiting, drowsiness. This is very important to elicit. And then you can examine where the shunt is. Quickly, let me show you what consists of VP shunt. This is the ventricular end. This is the dome, the shunt, this where the CSF, if you want to obtain a sample, we prick this to obtain a sample. And then the other part is the part that goes onto the chest, and this part goes into the abdomen. I bring your attention to the image on the right, similar one, but a longer tube to illustrate to you that this is the ventricular end, this is the reservoir or the dome that I mentioned earlier, and then this part goes into the abdomen. Any of this part can get blocked. This can get blocked. This end can get blocked. So CSF, if this gets blocked, CSF will not flow into the system. If this gets blocked, the lower end gets blocked, CSF cannot come out of the system. Now, if the dome gets blocked, nothing can pass through, either up or below. So how do you check this? One is the symptoms. Two is you can press onto the dome. No issues there. There's no problems at all. You can gently press onto the dome. Now, if the dome you cannot press, you know it is blocked. Something is preventing the dome from going down. What is it? Is it the CSF below it? So therefore, when you're pressing onto the dome, you're trying to press it down. It doesn't want to depress. Why? Because there's a lot of CSF accumulated. You know it's malfunctioning already. Or you've pressed it and you've pushed up the CSF, but it remains depressed. You can see a dimple. You can feel a dimple here. Why? Because there's no new CSF coming to make the dome rise. So it's always flat. Why? No new CSF is coming in. Why the no new CSF? Because the ventricular end is blocked. So therefore, after you squeeze this, you find the dimple for the next 1, 2, 3 minutes. That's not normal. This dome is designed, the moment you press, it goes in, then it pops back again. You press it in, it pops up in again. So that is functioning. Of course, this is not the 100% foolproof method, but it gives you a clue. Next, if you look into the shunt tract where the shunt is running, if you see it's inflamed, reddish in color, pus is discharging, that's bad news already. So please refer to the hospital. If you are lucky enough, or if your clinic is large enough, you've got an X-ray facility, then you can take a shunt series. Fancy name for actually X-ray of the neck, showing the shunt, the continuity, then of the chest, then of the abdomen. This is a shunt series to see if there's any disconnection, because how we put this together is the ventricular end of, there are different models, but the ventricular end is normally tied to this end. The peritoneal end is tied to this end. It can get fractured and dislodged, therefore affecting the flow of the CSF. The other thing sometimes is this tube itself over the years, many years, 8 years, 9 years, 10 years, it becomes fragile and fractures. So it breaks there. So if you take an X-ray, you can see the fracture. Or because of the fracture, the CSF will flow. Because of the fracture, the tube is pulled into the abdomen and goes into the peritoneum. So you'll see missing part, and you do the abdominal X-ray, you see the residual tube sitting in the pelvis, coiled there. So that is one thing for you to take note of. If it's infected, then you have a fever. So again, check for the tract, and you can, if your clinic has got you can take blood, check for the total whites. Now, the following discussion is, although very basic, very basic, but I've seen this so many times that I believe I must highlight this. I must share with everybody and anybody possible. I discuss this with the patients, and I'm now discussing this with my fellow doctors who are general practitioners, to highlight what I often see in the hospital. Now, with the Riles tube, just about 3 nights ago, I was on call, and then this family comes in. with a young girl brings her brother, and she said, "Oh, the tube has slipped out." So the ED nurse inserted it back again. And while she's there, this girl feeds her brother from the syringe. What she does is she puts the milk into the syringe and with the plunger quickly pushes the milk in. It goes to show that when the brother has got head injury, when the brother was in the hospital, the medical team has failed to inform or to teach her that this is the wrong method, and she is practicing this. So that's dangerous. I'll come back to that later why. The other thing I noticed in my previous practice when I was working in one of the general hospitals was many of our patients deteriorate early in the morning, 2, 3, 4, 5, 6. I always used to wonder, why is this happening? When everybody's around, that's not an issue. Why is this found dead, BP suddenly crash, GCS suddenly drop? It's always suddenly. It's like Hindi movie, suddenly this, suddenly that. There's no slow, gradual. Then one day I was watching my nurse feed. Then it's clicked in my mind that early in the morning, there are very few nurses, and feeding time comes. What the nurses do is they lift. Of course, they don't use a plunger. That's a disaster. But they lift the tube, the syringe high, so the the milk will flow very, very fast. And when it flows fast, because the nurse wants to finish her work fast, I can't blame her. At night, it's only skeleton crew. So this feeding needs to be done rapidly. You lift it up with the gravity pull, the milk flows very, very fast. Abdomen gets distended very rapidly, and the milk regurgitates upwards through the esophagus into the trachea. So patient aspirates. And if he's lucky, people will see. If not, the nurse will feed and move on. As it is, patient GCS is not good. 9, 10, 11. He cannot even tell you what's happening. So if my esteemed colleagues, my GP friends can educate family members how feeding is extremely important. Proper feeding technique is extremely important. Fact number 2, this Ryle's tube itself has a lot of side issues. Sinusitis is one of them. And this took me some years to understand. So we have patients in the ward having high spiking fever. I've done blood CNS, urine CNS, tracheal CNS. No, nothing is growing. Then I call the ID physician. Hey, can I have the help? Sure. He comes. He sends the patient off for ultrasound abdomen. Done. Nothing there. Then he says, Gurmit, we have to do something. Why don't you do CT contrast? You just did the surgery. Maybe there's abscess there. Okay. Done. CT contrast done. No abscess. Then he says, Gurmit, I think you better do an LP. Okay, done. That also done. Still cannot find the source. Patient is spiking fever. We have gone to high level antibiotics already. Now we are going to Tazo and whatnot. Then I realized one day, how come this Ryle's tube it might be possible causing a lot of problems in there. And we did a skull X-ray, sinus for sinus, and the sinus were opacified. We took the patient immediately to a theater, and my ENT colleague was very, very kind to come post office hours. And when we opened the ostia, the maxillary ostia, the pus was like waterfall. It fell like that. And when the patient came back to the ward, the temperature started to fall immediately. So it gave me a lot of, it was a major lesson for me. So here I'm sharing it with the GP. If a patient comes with a long-term, if you ask me how many days after insertion of the Ryle's tube can I get sinusitis? We were trying to do a study in my observation in HKL. Within 5 days, we can get sinusitis. How does this happen? The tube that's in the nose keeps abrading the mucosal surface within, and the maxillary ostia is all there's mucus around the maxillary ostia. So once you abrade against that, the mucosa is inflamed. It will shut the ostia, and the maxillary secretions cannot come out. They remain within, and there's always bacteria. It will grow within and cause infection. So this is a small pointer that I want to share with my GP colleagues. Please keep your eyes open for sinusitis in a patient with Ryle's tube. Number three is, I've seen how people secure this tube to the ala. It is I'm not very sure why people do it very, very tightly until there's necrosis. I've taken photos here from the internet to highlight to you what happens when people tie this, when secure this extremely tight. It causes necrosis. It causes necrosis here. It's not very clear here, but it causes damage to the ala of the nose. It's extremely, extremely, extremely painful. What's the option? I secure the tube to the cheek. I first put a duoderm layer or colloid dressing, any colloid dressing, get it stuck to the cheek, and then on top of the duoderm, I put the tube, so that if I don't put the duoderm there, it leaves an imprint onto the skin of the cheek. So what I do, I put a duoderm, on top of that comes the tube, on top of the tube is a tegaderm to secure this in place. So I leave the nose free, it is secured here onto the cheek, and the tube runs into the nostril. It works. I've never had problems with that. It's much more cleaner also. I also recommend you to change to a softer silicone tube, which is less painful. Of course, it's more expensive, but less problems. But the end to all these problems is, I normally will tell my patients to consider percutaneous endoscopic gastrostomy. So you do a PEG, you remove this tube from here, you put it, transfer it down here. It's larger bore, you can feed easily, patient can feed himself also. It's much, much cleaner, neater, and does not disturb your facial appearance. The whole world does not need to know you are on a Riles tube feed. You put the PEG tube under your clothing. And once you're well, then you can just pull out the PEG tube and the wound closes by itself. So there's not much of an issue there. So please consider suggesting this to your patients who are long-term Riles tube users. For me, anything above 3 weeks, I start to consider this already. Now, it's so simple that people will say, what's a big deal about urinary catheter? I see this often. And I want to highlight this. This again, the GPs will not be seeing patients in the ward, but this is to highlight so you can educate your family, the patient's family members also. I'm sure you have a lot of stroke patients, a lot of patients on urinary catheters. The position of the urine bag is extremely important. If it's on par, at the same level as the patient, urine will not flow into the tube, into the urine bag. It will get accumulated within the bladder. So there's a risk of urinary infection, distension of bladder, stone formation, all that consequences. Therefore, I always tell my family members, yes, you're going back with the urinary catheter. Please ensure that it is on a below the patient level, so the urine will flow down into the tube, not remain on the same level. Second thing is, I also tell them, please be careful that the tube does not go under the patient because this will occlude the tube and urine might not flow. The second thing is, the third thing, is erosion. I've taken this image from the internet. This tube was in situ for a year, whole year, and it has eroded into the ventral part of the urethra, the glans penis, everything, the distal part of the urethra, everything is eroded. When I saw this, I was thinking to myself, what were the doctors doing when this was happening? So obviously, one, the patient probably did not consult anybody. Two, there might be somebody who's saying, it's okay, don't worry, we can do this, we can do that. But I must highlight to you all that this is a very, very real problem, and it can happen to any of our patients. There is another bad habit that we have. After we insert the catheter, there's a tendency to pull the catheter and secure it to the thigh. This is commonly done in acute situations like in the ICU and all that. But I don't think so it's done at homes where my colleagues will see. But this is a possibility. So please keep your eyes open for this. Option, condom catheter. Again, this is not without its problems. I have seen patients who this circular band is applied so tightly that it causes abrasion, maceration of the skin around the shaft of the penis. If you tie too tight, it can cause necrosis. I've not had the misfortune of seeing that, but I've seen that circular band being tied very tightly. It causes abrasion, injury to the shaft, injury to the prepuce, the penile skin on the shaft. Bowel care, again, something so menial, so trivial, but very, very important. I've seen patients who have not passed motion for 1 week, 2 weeks. Why? Because I, as a surgeon, before sending him back, I neglected to tell him, I neglected to tell the family, look, your father now is just recovering from a fall. He might not be able to pass motion. All the medication we are giving also can cause all this problem. Please ensure I'm giving you this lactulose, I'm giving this ravine. Please administer high fiber diet. If it does not come, probably you can do digital evacuation. This is where I have neglected in my ward. Hence, I am sharing this with you again. I'm reiterating that probably the GP also can teach the family how to do manual digital evacuation of the fecal matter from the rectum. Pressure source. This I took it from my ward. Of course, sorry, not my ward, my department, but not my ward. This is a disaster. This is a disaster. It's a major disaster. What has happened is, before I go further, I always ask this quiz from my nurses, trainee nurses, medical students, medical officers, specialists. I ask them, you come to my ward, and if you see this, who do you think is at fault? A, consultant; B, specialist; C, MO; D, HO; E, nurses. Many a times the answer comes back as nurses or HO. But the correct answer here is, I would really love to hear what the GPs are thinking, but the correct answer here is the consultant. The consultant's responsibility. Many a consultant is like standing at the foot end of the bed, bye, with, it's like a bituki, no? Hi. That's it. Then you move to the next bed. Smart, bye. Everything is bye. And then you do the macro decisions. The micro decision, you leave it to a specialist. Lousy specialist gives birth to a lousy, lousy consultant gives birth to a lousy specialist. Lousy specialist causes a lousy MO, and the husband is watching everything. The top 3 guys in the department are not doing anything. Why should I bother? That's it. The nurse is laggy. Nobody is bothered. I'm so busy writing reports. I spend most of my day writing reports. That's it. So the whole system collapses. But you will see this kind of patient. If they will come to you, either caused by us at the hospital or at home. Why? Because nobody, the doctors, the surgeons, did not bother telling the family, hey, you need to be watch out for this. You know? When it happens like this, it's a very expensive affair. So if the GP sees this, I think this is a bit futile to treat in a primary situation. So you send back to whichever hospital it's come from, they will treat, and then you can continue, the GP can continue the care, the further dressing. I always tell my families to purchase a Ripple mattress. You can get this model of Ripple mattress on the on the online shopping, Lazada or whatever it is, for 115 ringgit. This is the bare minimum that you need. Of course, you can go to the high end, 2,000, 5,000, 10,000, the 20,000 models also. But I think the most economical amount will be this Ripple mattress, 115 ringgit. You can get it from Lazada. Very, very important. Please keep the bed sheets dry, because you keep them moist with sweat, urine. They will macerate the skin. Once the skin is broken, the bacteria will gain ingress, and that's the beginning of the end. I always tell my team members, bed sore is the beginning of the end. The patient came for some other problem, and because of our neglect, the doctors, the surgeons neglect, patient has developed one bed sore. In the US, you'll get sued. Of course, in Malaysia, it's a different story. In the US, you will get sued because you obtain another injury in the hospital. Now, the third thing is, sometimes we want to advise family members is to avoid leaving urine-soaked pampers or feces on the patient. These are small things. Probably not many have realized, but over my years, I've seen these are very, very important things. And commonly, we do not pass this information to family, leaving it for the nurse to do, but she herself is busy, she might not be able to do all this. The final thing in this cycle of prevention of bed sores is nutrition. It's extremely important to have good nutrition. You can suggest to them any of those liquid diets, but I would prefer if they can supplement their diet with this liquid diet. So they try to eat something. At least it keeps the oral cavity clean. They can have something to chew on, keeps them stimulated. Rehab, again, is not the primary care physician's domain, but I want to highlight to you, if you see a patient who's come back, I would suggest that you can recommend them to go for rehab. Why? Our aim is to mobilize them quickly to perform, so they can return back to performing their activities, the daily living that contributes to the quality of life. In the end, the ambition is to either maintain the quality of life, and if it's not there, then bring it up to reach the pre-accident level of quality of life. You can do physio, they can do to regain their balance, strengthen the muscles, because if the muscles are not strengthened, getting up from bed itself is a hassle. Patient sits into a sofa, wants to wake up from the sofa, cannot wake up. That's where all the falls happen. Sits on a toilet bowl, wants to wake up, cannot wake up, slips and falls. Want to wake up from the bed in the morning, rushing off to pee, slips from the falls down from the bed. So these are very, very important things. We need to strengthen their muscles. For patients who are very badly injured, we'll definitely want to avoid contractures. Therefore, if the GP can advise, please continue with your rehab, please continue the physio, and if they see patients are starting to develop contracture, refer to a rehab team for splints, for Botox injection. Tendon transfer is the extreme end. I've never done any, but this is one of the possibilities that you can correct these contractures. And then breathing exercise. This you can do, I believe. So you have an incentive parameter in your clinic. You can sell it to them. You can give it to them, so that at least the least they can do is to inflate their lungs, so that there is no consolidation, no accumulation of phlegm within. Therefore, the chances of them getting orthostatic pneumonia is lowered. Again, very, very sensitive topic. I'm not very sure how many GPs will touch on this. Neither did I. Until a couple of years ago, I had two lady patients, two lady patients who cried in my clinic, in my room, and told me how the loss of sexual function has caused a lot of problems in their family life. Of course, this was a tumor situation, but that gave me an idea how important sexual life is. Nowadays, I ask, please do not be mistaken. 70-year-old fella, sex is not important. I want to highlight to you, in this very place I'm sitting 3 days ago, there's a gentleman, 70-year-old, with some medical issue, who asked me, doctor, I cannot have an erection. Why is that? So it set me thinking again that, look, it's extremely important, however much you want to pretend, it's not important, I'm okay, I'm 70, there's nothing much to do. I beg to differ. So if there's I think sexual function or intimacy is extremely important. It can great if it's continued. There's significant material online for us to refer to. You always can refer the patient. If you're stroked out, there are different positions to adopt. Not the common. There are some variations of the normal sexual positions. Please keep this in mind. It might seem funny, it might seem trivial, not important, but I think it's vital. The two ladies who came to my room, who cried, not on the same day, but on different occasions, highlighted this problem to me. When I write medical reports for lawyers, I also ask these questions very pointedly. It's embarrassing for the patient to tell me, but I must take the courage. I teach all my MOs, I teach all my specialists that when patients come, especially head injury patients, of course slightly youngish, come to you, you ask them this question: how's the sexual function? How are things going with you? It's very, very important. This again is very, very challenging. I think even for the psychiatrists, this will be challenging. Why? Because there's coexistent degenerative brain disease. You already have brain problem, Parkinsonism, degenerative Alzheimer's, all that. But with this frontal lobe injury or contusion on the brain, on the occipital region, somewhere, some injury somewhere, patient starts to be agitated, gets very angry, or starts to be withdrawal, or starts to have apathy, doesn't want to eat, doesn't want to drink, I want to die. So if you can able to pick this up and quickly refer to a geriatric psychiatrist, we can arrest this problem there rather than let it spiral out of control. Because once it spirals out of control, when you drag the patient up again, it's very, very challenging. It takes long time, more medication, more money is involved. If we can catch it early, we can address it way faster. The second point there is caregiver burnout. Often missed is the caregiver. Nobody thinks about the caregiver, but the caregiver is the most important person in the recovery of this person. Be it the man's wife, the children. What happens is in this kind of cases, the elderly patients, children are staying away. Only the wife is left with the patient, or only one child who is resting, who is sharing the home with them. That person takes care. But because it's so intense, you need so much of time, so much of energy, that in the end you get tired. Then you have dark thoughts coming to you. These are especially patients who are immobile. Better for him to go. The quality of life is not good. All these dark thoughts will come to your mind. So we want to take care, take care of the caregivers' welfare also. It's very, very important. They're integral part of the recovery. The doctor thinks he is the most important guy, but actually there's an equally important individual here, is the caregiver, because all your message will flow into the caregiver, and through the caregiver into the patient. Thank you very, very much.
Thanks a lot, Dr. Dr. Gurmit. I think we don't have much question, but I have the questions that I would like to ask. One will be, a patient just met in a motorbike accident. He was wearing a motorbike. He was wearing helmet and everything. He came to the clinic with a little bit of abrasion, and also there's a small laceration over the upper limb and the lower limb. But he wore a helmet and he was very fine. Is it warranted to refer him to a neurosurgeon, or should we observe him in the clinic, or should we ask him to come to the next day to the clinic? Which will be the best variant?
Dr. Ora, you have given three options here. One, you have said come back next day. Two, you have said observe in the clinic. And three, nothing much. You dress the wound and send him back. Am I correct? Those three options.
No, the third one is to send him to send back to neurosurgeon. Refer to a neurosurgeon.
Refer to a hospital. Doesn't matter neurosurgeon. Refer him to a hospital. If that person is elderly, above 60, 65, because the atrophy is there, there's a lot of space in the brain, number one. Number two, on aspirin especially, I will send him to the GH. I'm sending him to any hospital, because he needs close observation, he needs care. If it's a younger person, 40, 50 plus, then I can dress the wound, observe you have a GP, you are very busy clinic, you're not going to keep this patient there. I will tell the caregiver, look, this is the injury, there's slight abrasion here, but because he's not on aspirin, he's not very elderly, please keep an eye out for this. Advice is known as head injury advice. Every patient of mine with head injury gets this advice. If you go back home, if it's nausea, vomiting, please come back immediately. If you go back home, you found him to be drowsy, not arousable, not alert, please come back immediately. If you go back home and you see he cannot swallow, he's starting to drool, speech starting to become slurred, not clear, please come back immediately to the hospital. So we will give all this, you can give this head injury advice.
Okay, doctor. There's one more question I want to ask, doctor. Usually post-operative, any type of surgery, brain surgery, the patient after the surgery in the hospital, they go back home. When they go back home, how sometimes the surgeon will give a plan, like, you come back after 1 month or 2 months. But the thing is, even in 1 week, when can the GP, like most of the family members, they get a bit worried. They want that the patient is not as he went into the hospital because it was a very acute, maybe it's an accident or something. So they want a doctor to be like by the side, because in the hospital is taken care by the medical team, and now they're home, they feel a bit of worried. So the first person they will go into the nearest GP, and then they will ask the doctor to come and review. So what will be the best advice, and how early should the doctor go and review the patient? How many days after that? That'll be
One of that question is a challenge to answer. Why? Because we do not know when the patient will deteriorate. Agreed? I do not
yeah.
know when hydrocephalus will strike. If I know hydrocephalus will strike on day 12, I will do a CT scan on day 11. If I know hydrocephalus is going to strike on day 42, I will do scan on day 41. I will not waste money, time, effort. I will only do. So hydrocephalus is a tricky game. Others also, like you said, could it be abscess? I've taken out the tumor. Unfortunately, the cavity in there got infected. So he's got a empyema. How will the GP know? The GP will look for constitutional symptoms. So let's divide this into a couple of things. Infection. Patient family calls the GP to please come and see my loved one is having high fever. So you come, you examine. See, first thing is the wound. Is it inflamed? Is it broken down? Is there pus coming out from it? Because the surgeon can operate and the wound is infected. By the time he reaches home, the wound is starting to gape. There's a lot of pressure, the pus will escape. So the GP can examine the wound. The GP can examine is there any other pressure source. The GP can examine and see if the Ryle's tube is in the right place. If there's any, open the mouth and look behind if there's nasal drip, if there's pus falling down on the posterior pharyngeal wall. Because from the ostia, it'll exit and fall. Because you're dependent, it falls back. So open the mouth and look behind. You see yellow streaks of pus. And then, if the patient is shunted, then you look at the shunt tract if there's any infection. Of course, you won't have X-ray with you in the patient's house, but these are the small things that you can quickly assess the patient. Then you do a general examination also, you check the pupils. See, if you check the pupils and see it dilated, then you know it's a space occupation or the intracranial pressure is going up.
Yeah. Okay. And I think one more last question, doctor. As we know, now is COVID, the pandemic is all around us. There's so many SOPs are started. So how do SJMC, how do they divide acute patient, tumor patient, and a patient with an MVA? How do you all divide them, and how is the SOP taken? PCR and all the stuff. How do we approach this type of cases, the acute, the emergency cases and the non-emergency cases?
All the cases, the emergency cases, when you come to ED, they immediately do a rapid test for you, and they will see if you are positive or negative. If negative is okay, then you can go to OT without all the precautions. If you're positive, you're found to be carrying COVID, then all special precautions are taken. We gown up, all that PPE, all that disposable equipment, everything is taken care of. So that becomes a bit more of a challenge, but then you must acknowledge that you don't want to spread the infection within the hospital. If that happens, it spreads very rapidly within the whole hospital might be shut down. You never know that. So for the COVID patient, we take special precautions. We test your COVID. If you're negative, you are sent. If you're elective, you're sent to another holding ward. There, they will do the PCR. Only when your PCR is confirmed, then you come to the general ward and wait for your turn for surgery. If emergency, then we do the rapid test quickly, and if there's suspicion, then we gown up properly.
Okay, doctor. I think that will be all. Our speech is going on for past 1 hour, 10 minutes already. I would like to thank for all the information. It was very good, and thanks a lot, Dr. Gurmit.
I want to, Dr. Vara, I also want to thank you for moderating this. I want to thank all my general practitioner colleagues, the primary physicians, primary care physicians who are on board here. I want to thank them for the time. It's a Saturday, but they took the time to join us. My contact is there. If they want any additional other information, any other advice, I'm more than happy to be contacted. Thank you. Thank you, everybody.
Okay, thank you, everybody.